Bismillahirrahmanirrahim. Qalu subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. So we'll be talking about the basic principles of mechanical ventilation. In this, I'll try to cover the different definitions of different modes of ventilation and why we do those particular modes. On this particular topic, we'll discuss these things only, and then the next lecture will be on the physiology of ventilation. Then the third will be on disease-oriented ventilation. Now, basically, what is breathing and how does it work? How you breathe? Breathing is, before I say about something about breathing, things always flow due to pressure gradient. Things flow from higher pressure to lower pressure. This is true for the gases as well as for the liquids. So, in addition to the physical properties of a substance who is going to diffuse, so it's a pressure gradient which is very important. So, the things diffuse, whether the things are diffusing in a gaseous medium or it is diffusing in the liquid medium. So, in addition to pressure gradient, so there is some physics laws which applies to it for the diffusion. Now, when we breathe in, our inspiratory muscles pull the chest out and create some subatmospheric pressure. Now, as the pressure outside is greater than the inside pressure, so due to pressure gradient, the gases go into the lung and the lungs are expanded. Now, when the inspiratory muscles stop contracting, then the chest recoils back, and then there is a positive pressure as compared to atmospheric pressure, then the gases come out. So, when the gases go in, we call it inspiration. When it goes out, we call it expiration or exhalation. I divide this breathing into two portions. One is respiration, other is ventilation. The respiration is a negative pressure breathing, and ventilation is positive pressure breathing. Now, if you're breathing, that's a spontaneous breathing, that is spontaneous respiration. And if the patient cannot breathe, but you want to give negative pressure breathing, then you put on respirators. So these are the respirators which are around the chest, and they create negative pressure in the chamber, and that creates a negative pressure to the thorax, and the gases are pushed in because of pressure gradient. So those were originally designed and they were called respirators, not ventilators. And there are still lying in a museum, those respirators. Then ventilation is again divided into two: artificial ventilation. And artificial ventilation is when the patient needs ventilatory assistance, or patient cannot breathe or cannot maintain his blood gases, so we'll have to put on an artificial ventilator. And in that we put the positive pressure into the chest to create the pressure gradient from the ventilator to the chest. So if the patient cannot breathe, we give artificially, and it is a positive pressure ventilation. Then again, positive pressure ventilation is divided into two portions. One is low frequency positive pressure ventilation and high frequency positive pressure ventilation. These are two different topics. Now, basic principle, when they design the ventilator, there are three types of basic principles on it. One is the pressure generators, then flow generators, and then is a combination. In some of the ventilators, when the companies they make, they are asked that what type of ventilators are they? Are they pressure generators or flow generators? Or it is a combination of both systems in the one ventilator. Now, controlled mechanical ventilation, there are basically two modes which we use. There are no third mode. Other modes are just a facilitating mode, or you can call weaning modes. And one is a volume control mode and the other is pressure control mode. When we put on a volume control, we set the volume on the ventilator, then we look at the pressure, that how much the pressure ventilator has to generate to push that volume into the lung. So those are called volume control mode. And when we put on the pressure control, we set the pressure, then we look at the volume, how much volume it's sending in. Then as we have got in our mind that this volume should be there, so then we fiddle around with the pressure. So we can increase the pressure, we can decrease the pressure. So these are basic two modes. One is the volume control, other is pressure control. When we put on a volume control, we set the volume, and then we look at the peak inspiratory pressure, how much pressure this ventilator has to generate. Then when we put them on pressure control, we set the pressure according to the required volume. Then we look at the volume, how much is being delivered to the lung. Now in this whole mechanism, starting the inspiration, maintaining the flow of gas into the lung, and then terminating the inspiration, and then starting the expiration. This is called triggering mechanism. And this triggering mechanism, it could be time cycle, could be flow cycle, could be pressure cycle. So three types of cycling. From inspiration to expiration, from expiration to inspiration, there is bound to be cycling. It is adjusted in the ventilator, but you just choose it, whether it is a time cycle, volume cycle, or pressure cycle. Then there are some weaning modes. This is PRVC, pressure regulated volume control mode. Then there is synchronized intermittent ventilatory mode under pressure. Then there is synchronized intermittent mandatory ventilation with volume control. Then you have got CPAP, continuous positive airway pressure. And if you combine CPAP with the pressure support, it becomes BiPAP. In BiPAP, there are two portions. One is IPAP and other is EPAP. IP means inspiratory pressure, how much you are putting the pressure so to push the gas inside the lung. Then APRV. APRV is airway pressure release ventilation. This is also according to pathology of the lung. We choose this mode when we are weaning the patient. Then you have got ASV is another one. This is called adapter support ventilation. So we rarely use these, but the main is pressure control and volume control ventilation. But when we put them on BiPAP or only on CPAP, patient should be breathing on his own, on her own. Breath should be taken by the patient itself. So we only give them just a support, inspiratory support and expiratory pressure we leave in the lung, which is called CPAP. So with the CPAP is a continuous positive airway pressure. When the patient is on ventilator, we don't call it a CPAP, we call it as a PEEP, positive and expiratory pressure, to recruit the lung, to keep the lung, to keep it open. Now, origin of mechanical ventilation. The era of intensive care medicine began with a positive pressure ventilation. There used to be negative pressure ventilation, that's called respiration. So negative pressure ventilation started, those were called iron lungs. So they used to have a chamber around the chest and create negative pressure and pull the chest out and create a pressure gradient, and the gases used to go inside the lung. So it was first started in 1928 in America, as usual, Boston Children's Hospital. Then it was used extensively during the polio outbreak. So that helped a lot. That created the idea that we should have a controlled ventilation with the positive pressure ventilation. Now, positive pressure ventilation, first time it was started in 1955. Again in Massachusetts General Hospital. Now, the modern standard of mechanical ventilation is ventilators, which we are using. Different companies are making different ventilators. So to set the settings on the ventilator, you will have to look at the literature of the ventilator, which has been designed by different companies. But these are the basic principles. On what principle we are delivering the gases to the lung. There are 2-3 things which needs to be clear theoretically. One is ventilation versus oxygenation, and pressure cycling versus volume cycling. Now, when we talk about ventilation, we say ventilation, immediately we think about the carbon dioxide. PaCO2, partial pressure of carbon dioxide in the arterial blood. We think about it when we talk about ventilation. And oxygenation, when we talk about oxygenation, it means how the oxygen is being delivered to the blood. So that is the main objective. When we are putting the patient on a ventilator, our end objective is that whether the adequate amount of oxygen is going to the blood or not, or whether the carbon dioxide is being removed or not. That's the objective. But we use different devices, we use different modes to get our target. So then we'll have to set the mode. Then we have to fiddle around with the ventilator settings. Then we should know what are the indications to intubate, what are the indications to put the patient on a ventilator, what are the indications and to extubate the patient also. So these are all these things theoretically should be in front of you. Then you choose the modes of ventilation, then choose the volumes of ventilation. Then there are a few questions arise from out of it. Now, if you look at this diagram, it's a very important diagram. On the right side, it has 3 zones in the lungs. It is John West classification of lung as far as the ventilation perfusion is concerned. If you look at the upper zone, now upper zone has got less blood supply as compared to other 2 zones. When there is less blood supply, so there is less resistance for the gases to go in. When the less resistance will go in, there will be more gas will be going into the upper lobe, upper portion of the lung. As compared to perfusion, it means ventilation perfusion ratio will be increased. It means there will be effect of dead space effect. When you go to middle zone, there is equal amount of blood and the volume is coming there. So ventilation perfusion ratio is normal, so that's the best zone. When you go to the lower zone, there is more blood coming there. As there is more blood, there is more resistance for the gases to go in. So it means the gases will be less gases going there, so ventilation perfusion ratio is decreased. So it means there will be shunting of blood. There will be shunting of blood, and in the upper part there is a dead space effect. In the middle part, there is adequate ventilation perfusion ratio. In the lower part, there is more perfusion as compared to ventilation, so there will be shunting effect. So when you are standing up like this, when you are lying flat, then the zones become like this. When you are prone, then the zones are changed. So these zones, these are the positioning advantage we get by changing the posture of the patient. If you want to make the lower portion more ventilation, so it means you will have to lower the head. So in the way, if you want to make more ventilation in the upper part of the lung, you make the person sit up. So prone position is very ideal position for mobilizing the secretion and for avoiding the atelectasis and for opening of the lung. Now, minute ventilation is nothing. It's a product of respiration with the tidal volume. What is tidal volume? Tidal volume is the amount of gases which goes into the lung and come out, or amount of gases will come out of the lung with single breath. That is the tidal volume. If you multiply the tidal volume with the respiratory rate, that will give you minute volume. So it's the expiratory minute volume is more important than you have set on the ventilator of inspiratory volume, because we don't know how much the gas is going in. The gases which are coming out of the lung, that is the amount which actually has gone into the lung. So we should always monitor the expiratory minute volume, not inspiratory minute volume. In inspiratory minute volume, we should adjust, but the expiratory minute volume we should assess or note it. So that will tell you whether there is any leak or not. So it should be equal, almost equal. So alveolar ventilation, in ventilation, you have got 2 portions, alveolar ventilation and dead space ventilation. Now, alveolar ventilation and dead space ventilation is, we make a ratio of that. The alveolar ventilation means it is going into that part of the lung where there is an exchange of gases between the blood and the alveoli. So that starts from respiratory bronchioles below, that is from 16th generation to 23rd generation. Now, conducting pathway has got dead space ventilation. There are the gases, it is just a passage. The gases are going there, but there is no exchange between the blood and between the gases. So if you look at it, if you make a ratio of VD is the dead space ventilation divided by alveolar ventilation, so that is 1/3. Now 1/3 of the gases do not come in contact with the blood, and 2/3 they come in contact with the blood. Now if you increase the dead space, you will reduce automatically the ventilatory portion. So it means you will have a dead space effect. If you decrease the dead space, then you will have more ventilation, you will have more passage of gases. So ventilation in context of ICU. Now in ICU, if there are conditions which produce more carbon dioxide, like a fever, like sepsis, and like if there is injury to the chest or overfeeding, these are the conditions which you will have to look at. When the patient is in ICU on ventilator, that these are the things, they produce more carbon dioxide. So we'll have to wash out the carbon dioxide from the body also. And there is an increase of dead space in some conditions, like atelectasis, lung injury, ARDS, pulmonary embolism. Your dead space increases more than the ventilatory area. So in both the things, we'll have to adjust the respiratory rate and the tidal volume. If there is more carbon dioxide being produced, you increase the respiratory rate and you increase the tidal volume also to get rid of carbon dioxide. So same way, if there is dead space effect, we'll have to look at the respiratory rate and look at the tidal volume also. So these are the parameters which should be adjusted. Then we come to oxygenation. Now oxygenation is what are the things by which we can maximize the oxygen which goes to the blood? That is, in the blood means we look at the PaO2, partial pressure of oxygen in the arterial blood. That is our objective of ventilating these patients. Getting rid of carbon dioxide and having the oxygen into the blood being delivered. So in that important, when we use the blood gases, the most important parameter is to look at the partial pressure of oxygen in the alveoli, P big AO2, and you look at the partial pressure of oxygen in the blood, that is P small AO2. Then you look at the difference from the alveoli to the blood. Why there is a difference? There is a normal difference of 3 to 8 millimeter mercury or maximum 10 millimeter mercury. But if that difference increases, it means there is a problem between the alveoli and the blood. Might be alveolar epithelium is thickened or some problem with it, or might be the problem in the interstitium. There might be problem with the capillary endothelium. There might be the blood is not coming required amount. So that's called alveolar capillary pathway. We'll have to look at the alveolar capillary pathway. Now this thing, the P big AO2 minus P small AO2, this is called AA gradient. Now you can calculate yourself if it is not a provision on your blood gas analyzer. If there is a provision, you look at it. Our blood gas analyzer gives you all the information, but otherwise you should be able to calculate yourself also. So this is very important. Now the PaO2, partial pressure of oxygen in the arterial blood, depends on the ventilation, but more on the ventilation perfusion, ventilation shunt occasion. So it depends both on that. But on ventilation, it also depends, but more depends on the ventilation perfusion ratio. That's very important. Okay, how much of the gas is coming into lung, how much is blood going there, whether they are matching or not. That's very important. Then if you look at the oxygen status in the ICU, so it depends what is the position of the patient and whether the patient is in a supine position, sitting up position or prone position. It will make a lot of difference in ventilation perfusion. And if you increase the ventilation perfusion, normalize, then you will have better oxygenation. So for improving the oxygenation, you will have to fiddle around with the fractional inspired oxygen. How much oxygen you give to patient? You might be giving 30%, 28%, 40%, 50%. Accordingly, to have the desired effect of partial pressure of oxygen in the blood, you will go on increasing the FiO2. And the second thing which you do is, you keep positive pressure to the thorax to keep the alveoli open. That is called PEEP, positive and expiratory pressure. So that it should increase it will keep the alveoli open. When they are kept alveoli open, then the oxygen can reach to the alveoli and it can diffuse into the blood. So these are, when you're looking at the carbon dioxide, so you fiddle around with the respiratory rate and tidal volume. When you're looking at the oxygenation, you look at the FiO2 and at the PEEP. So these will help in improving the oxygenation. Now, again, as I said in the beginning, pressure control or volume control ventilation. Now, when it is pressure control, cycle modes deliver a fixed pressure. We adjust the pressure, and then you look at how much volume is going into the lung. And, for example, you have calculated, according to the body weight, that you want to give this much volume into the lung. That's usually 6 to 7 or 7 to 8 ml per kilogram. So if you have got in your brain that this much volume should go into lung. Now, either you adjust the volume, that is called volume control, or you adjust the pressure and look at the volume which is delivered by the ventilator. If it is not desired volume coming there, then you increase the pressure more. So, to control with the pressure. So, in a pressure cycle mode, it could be only pressure support ventilation, it could be pressure control ventilation, could be only CPAP, or could be BiPAP. These are the different modulating modes of pressure control ventilation. When we talk about pressure control ventilation, if the patient is not breathing, it will be pressure control ventilation. But if you give patient is breathing, you want to support, that's the pressure support ventilation. If you want to give only, leave the pressure in the lung, patient is breathing spontaneously, it's called CPAP. When you want to support inspiration as well as expiration, then you put on a BiPAP. But on CPAP and BiPAP, patient should be breathing, patient should have his or her own breath. But for pressure support and pressure control, it is not necessary that the patient should be breathing on its own. It is ventilator which is pushing the gases in the lung. Then we come to volume cycle. Either you have complete volume cycle control, means patient is not breathing, or you have paralyzed the patient. You set the volume, look at the pressure, how much pressure is required to put that volume. Or you are just assisting. Patient is breathing, or you are letting the patient to breathe. But with a certain amount of volume, you support it, you set the volume that it should be delivered to the lung. Partly patient is breathing and partly lung is supporting it. Then assist control both mode, then intermediate mandatory ventilation. As soon as we put the patient on ventilator, our objective should be, after correction of the gases, we should bring the patient back. It's not a good thing to keep the patient on ventilator, because always remember, when you put the patient on ventilator, you immediately give trauma to the lung, because it is an unnatural way of breathing. Because as I told you, if it is a respiration, it is a negative pressure breathing. When it's a ventilation, it is a positive pressure breathing. When positive pressure breathing is against the natural way of breathing. So when anything which goes against the nature is bound to have some complications. So as soon as we put the tube down or put the mask on the face and put on the ventilator, there can be 3 types of trauma. One is barotrauma, other is volutrauma, third is biotrauma. Barotrauma is under the pressure. If you burst the alveoli, it can cause pneumothorax. Volutrauma is if you give large volume into the alveoli, it can stretch the alveoli and gases can pass through. It can cause, pneumothorax. Biotrauma is there are 43 types of cells in the lungs. Now they are used to negative pressure of breathing, natural breathing. Now you put a positive pressure, so different type of cells react in a different way. They secrete different type of hormones. So you will end up in some problems. So these problems you should keep in your mind. I'll discuss this in the second lecture more, because there are complications, physiological complication of ventilation. That is the physiology of ventilation. That will be our next lecture. So always keep in mind. But as we have in our mind that we have to bring the patient back, so we put on SIMV, synchronized intermittent mandatory ventilation. It means you are ventilating a patient, but you are giving a time for the patient also. If he or she desires to breathe, can breathe in between. It should be under pressure, or it should be only volume, SIMV volume. Now, pressure support ventilation. Now, patient determines the respiratory rate and expiratory minute volume, a purely spontaneous mode. Now, patient is breathing spontaneously, but you give support to the patient. हम धक्का लगा देते हैं पीछे से उसको, थोड़ा सा प्रेशर के साथ थोड़ा खुद लेता है, खुद हम उसको प्रेशर को निकालते हैं, IPAP करते हैं हम उसको. Now, parameters are triggered by the patient's own breath. Patient is breathing his or her own respiration, limited by pressure. You adjust the pressure that it should give certain amount of pressure to it to have a desired volume. Then it affects the inspiration only. If you give only pressure support, patient is breathing spontaneously, this affects the inspiration only. It does not affect the expiration. Now, it's very useful when the patient is put on volume cycle mode, and the patient is starts breathing itself, and you put a little bit pressure behind it so that it should normalize the tidal volume which is being delivered to the patient. Now, pressure controlled ventilation means that is a pressure support ventilation. It's a pressure controlled ventilation. This ventilator determines inspiratory time itself, and no patient participation at all. Patient is not breathing at all, and parameters are triggered by time. It is limited by pressure, and it affects the inspiration only. Again, disadvantage is it requires frequent adjustment. When you put the patient on a pressure control ventilation, you will have to adjust, because when the gas is going to the lung, it depends on the time constant. Time constant is nothing, it is a product of compliance and resistance. Now, with the changing pathology of the lung, it can affect the compliance and the resistance. Compliance and resistance will be changing. So it means you will have to adjust the pressure to have a desired volume. Suppose the patient's disease is cured and the lungs become expansile. So with the same pressure, now it can deliver more gases. So then you have to reduce the pressure. If the lungs have become worse, so you might have to increase the pressure to have the same desired volume. So you will have to be very vigilant when you put on a pressure control ventilation. You might have to adjust time to time to have the desired volume into the lungs. Now, CPAP and BiPAP. CPAP is very commonly used by the pediatricians or neonates. They put the nasal prongs for CPAP or tube or mask. Nasal prong, I don't know how much the effect they get. I'm always optimistic about it, because to have the pressure in the lung with the nasal prongs, if the child's mouth is open, it will not let the pressure build up. How can you say it is effective CPAP? So CPAP means continuous positive airway pressure at the lung, in the lung at alveolar level. So you will have to, mouth should be kept closed. Then you will have effect. Otherwise, the best way of CPAP is you put in the tube and connect with it. But there are masks also, which are the masks. You give CPAP with a mask. So then, if you want to give only CPAP, it is related to expiration. When you put on a BiPAP, it means you are giving positive pressure during inspiration, and if you are putting CPAP, then you are keeping the pressure, leaving the pressure in the lung during expiration. So if you want to combine both, this is called BiPAP. First portion is IPAP, inspiratory positive air pressure, and the other is CPAP, which is relieving the pressure in the lung, so it will keep the lung open and it will have better oxygenation. So it is depending on the pathology of the lung, we choose it. Now the patient is breathing spontaneously, why not put on a BiPAP so that we should keep the lungs open and gradually. For example, if you put the patient on a BiPAP on say 15 centimeter of water, IPAP and 5 centimeter of CPAP, now how would you know that the patient is improving? If the same volume which is being created by the lung, by the BiPAP, if the volume increases with, for example, 50 centimeter of water IPAP, so it means you will have to reduce the IPAP. You go on decreasing the IPAP when it reaches to 10 or 12. It means it is the normal now to take the patient off the BiPAP. So we wait till the inspiratory pressure sport decreases to around about 10 centimeter water, but then we remove the BiPAP and then the oxygen with the ordinary patient with the ordinary oxygen mask is okay. Now assist control modes. These you have to choose according to the ventilator you are using and according to the pathology of the lung. There are different modes, assist control modes, assist APRV and other things also. Just IMV, SIMV. IMV is intermittent mandatory ventilation. It means when the patient wants to take breath, there is a provision in the ventilator that ventilator should let the patient breathe through it. But it has got no relationship with the ventilator setting and the ventilator. It will not coincide with the inspiratory volume which is patient ventilator is pushing into the lung. But then they make synchronize. Just intermittent mandatory ventilation. Patient breathe kar raha hai, ventilator फेंक रहा gases, and your patient is breathing on his own, and they can attack each other also. They cannot, there is no synchronization. Udhar the patient is trying to breathe out and the ventilator trying to push in. But it used to work. Then they said, so why not to put on synchronize? That when the patient wants to breathe out on his own, on her own, then the ventilator should stop. Let him stop his breathing. Let her stop her breathing, and then the ventilator starts breathing again. So that is synchronization between them, right? So this is better mode, and you put on them as soon as you put on a ventilator, and you think the lungs are recovering. Now it doesn't need to be completely apneic. Let him breathe. Then you put on this mode, and gradually the patient takes over. So recruiting ho jati uski. So then we have to put the patient on BiPAP. After SIMV, we put on BiPAP. After the BiPAP, we put on TP circuit, and then we see if there is indication to extubate the patient or not. Extubation की indication को देखें. तो इस लिहाज से चलता है mostly. But in some of the patient, it's very easy to put the patient on a ventilator because it is our decision. And when the patient is taken off the ventilator, it is patient decision. That patient will take over itself and patient will come out of ventilator itself. So it's very difficult to wean the patient off the ventilator. It's very easy to put the patient on the ventilator. So it might take hours, days, or even months to wean the patient off. I've got a book written by very famous anesthetists in America. So it's a very big book, Weaning the Patient off the Ventilator, only weaning. There are multiple questions on that, so one must read it. So sometimes you are stuck with it, patient doesn't come off the ventilator. What would you do then? So then you will have to fiddle around with it. So it might take sometimes months. So it becomes a very difficult thing. Ventilator settings to improve the oxygenation. You have put the patient on a ventilator, but you are not getting the proper oxygenation. Patient is not getting proper oxygenation. Oxygenation means The state of oxygenation means you look at how much oxygen you are giving to the patient, that is FiO2, then how much is oxygen pressure generated at the alveolar level, P big AO2, then you look at the partial pressure of oxygen in the blood, that is P small AO2, then you look at the gradient. What is the gradient? That means what is the difference of pressure P big AO2 minus P small AO2. So then you look at the saturation hemoglobin, then you look at the total hemoglobin, because that is carrying the oxygen to the tissues. Then you look at the delivery of oxygen, that is DO2. Once it is delivered to the tissues, then how much is extracted by the tissues? Then that is called VO2. Then you look at the venous sample also, because that venous sample will help you to find out how much has been taken from there. Then last of all, we see if the oxygen has been taken by the tissue, whether the tissues are using it or not. To look at that, you look at the lactate level, because lactate is metabolism going on all the time. If you supply oxygen, this is aerobic metabolism. If you can't supply the oxygen or the tissue cannot use the oxygen, then it is anaerobic metabolism. And the product of anaerobic metabolism is a lactate. If lactate starts going up, even if your saturation is normal, even if your partial pressure oxygen is normal, even if your DO2 is normal, even if your VO2 is normal, you look at the tissue. Might be the enzymes are defective, which are required to use oxygen at the tissue level. Once you have done from up to that level, it means you have judged the oxygenation status of a patient. Now, if there is a problem somewhere, to analyze all the sequence, so how can you improve the oxygenation? First thing you look at is the FiO2, how much oxygen you are giving to the patient. From FiO2, you calculate the PiO2, under what pressure the oxygen is going, that percentage of oxygen at what pressure it is going into the lung. Then that will improve. You might increase if you are giving 30%, you might give 35%, 40%, 50%, you can go up to 100% oxygen to have the desired effect. It doesn't matter. Although giving a higher oxygen is a toxic gas also. So, but you have to improve the oxygenation. So, inadequate oxygenation, in spite of giving 100% oxygen, usually due to pulmonary shunting. Then you look at the shunting, that how much blood is coming into the lung, but it is not coming in contact with the oxygen. So it means there is some defect in the ventilation perfusion ratio. So that we have to look. It happens when there is atelectasis. Atelectasis, lungs, small lungs portions are collapsing. Then could be pus, filled alveoli or pneumonia, or could be water and protein ARDS, and could be congestive heart failure, or could be blood in the lungs. So you will have to scrutinize this. If by increasing FiO2 you are not improving, you have looked at the ventilator setting, then you look at the lung also. There might be blood coming into the lung, but it's not getting the oxygen through it. So there is an obstacle, but in the alveolar capillary pathway. Might be in the alveoli, might be in the interstitial compartment, might be in the capillary wall, might be in the blood. Now, ventilator settings to improve the oxygenation still. You put the patient on PEEP, positive angiographic pressure. It keeps the lung distended. You have fiddled around with the FiO2. Now you look at the PEEP. Now, what does the PEEP do? It increases the FRC, functional residual capacity. So that will improve the oxygenation. That will increase the diffusion of gases better. Now, it also recruits collapsed alveoli. It keeps them open, and it will help you maintaining the ventilation perfusion ratio. But always remember, if you put a positive end expiratory pressure, you are putting a positive pressure to thorax. This positive pressure to the thorax can hinder the venous return also, and it will reduce the preload. At the same time, it will also hinder the venous return from the brain also. As you have got a brain injured person, so it will increase the ICP, intracranial pressure also. You have to look at these everything. So hemodynamics can be disturbed, intracranial pressure will be increased also, but you look at the benefit, whether it is keeping the lung open or not, and whether it is improving the oxygenation or not. because you can deal with these things. If you have to put the patient on PE with a head injury, raise the head, take the gravitational effect to neutralize it. Then if the blood pressure goes down because the venous return is less, then you give the fluid more. If cardiorespiratory system allows you. So in that way you have to fiddle around with it, but you can give PEEP of 5, 7, 8, 9, 10, 15, even up to 20. But you should give optimum PEEP, and it has to be defined what is optimum PEEP. Now, disadvantage is you will have increased intrathoracic pressure and may lead to ARDS also. Then it can rupture the alveoli, can cause pneumothorax also, but it's good to clear in the pulmonary edema. So all these things have got advantage and disadvantage, and if the patient is on ventilator, it needs special care. Special care means special care by the nurse, and you should be very vigilant. One person should always be sitting there. It's not like this, you press the button and you have started the ventilator and you go around. No, it's not like that. If you're going for a break, another person should be sitting there and constantly watching the patient. Anything can happen. So ventilation, putting a patient on ventilator is a serious thing, and to look after the patient who is on ventilator, it needs very vigilant nursing care. Now, improve the ventilation. I said when you use the word ventilation, there are two things when you put on a ventilator. You have to look at the ventilation, you have to look at the oxygenation. Ventilation means it is related to carbon dioxide. It means you look at the carbon PaCO2, what is happening to it. When you use the word ventilation, it means you immediately think about the carbon dioxide. When you use the oxygenation, of course, you are looking at the PaO2. Now, oxygenation, we have just done it, that how to improve the oxygenation. Now, the ventilation, how can we look at the PaCO2? PaCO2, when you have put the patient on a ventilator, your CO2 either is going up or going down. If it is going up, PaCO2 is increasing. It means carbon dioxide is very fast diffusible. It comes very quickly from the blood to the alveoli, and from the alveoli it will go on coming till there is a pressure. There is no pressure gradient. You have to remove the carbon dioxide from the alveoli to the atmosphere. So that is first thing which improves is rate. You have to fiddle around with the rate of ventilation. You increase the ventilatory rate. And second thing is the tidal volume. You increase the tidal volume and you increase the rate, and it will wash out the CO2. If you wash out the CO2 from the alveoli, automatically carbon dioxide will come from the blood and it will cure the hypercarbia. On the other hand, if you look at the PaCO2 has gone down very much. So depending on the condition of the patient, sometimes we intentionally lower down the PaCO2, but sometimes reduction of PaCO2 is because of our bad management of ventilator. So it could be you are giving increased respiratory rate, or you are using large tidal volume. You adjust that to have a desired level of PaCO2. So when you think about the ventilation, you think about the carbon dioxide, you think about the respiratory rate, you think about the tidal volume. Accordingly, you adjust it. Having a high CO2 above 40, it means you are taking into respiratory acidosis. Having a low PaCO2, it means you are taking the patient into respiratory alkalosis. In a head injury patient or in the brain insult patient, we usually keep the PaCO2 between 30 to 35 and never ever go below 25, because washing out CO2 will cause constriction of vessel, particularly constriction of the vessel in the brain. It will cause more ischemia, it will enhance the already present ischemia. So you should be very careful when you are ventilating the patient who has got head injury or who has got intracranial insult. Now, IE ratio, inverse ratio ventilation. Now, normally IE ratio is 1 to 2. your inspiratory time, your expiratory time, double the inspiratory time. For example, if you are breathing 20 per minute, or to put the patient on ventilator 20 per minute, so it means how many seconds for one cycle, inspiration to expiration? 3 seconds. There are 60 seconds in a minute. Pata hai na aapko? Very good. So 60 seconds in 1 minute. So 60 seconds में 1 to 2 ratio है. 1 plus 2, 3. उसको divide करें 3 पे. So how much is one cycle? कितना बनता है? 20 रेट पे 3 सेकंड है. इसका मतलब 1 सेकंड में आप ब्रीथ इन कर रहे हैं और 2 सेकंड में बाहर निकाल रहे हैं. So the gases come out very slowly and the gases go in very fast. ठीक है. So लिहाज उसी लिहाज से टाइमर को सेट किया हुआ. Now if you want to improve the oxygenation, you increase the inspiratory phase so that you should give more time for the gases to stay in the lung to have a better diffusion of the gas across the alveolar capillary pathway. Now, if you've got expiratory obstruction, you make the expiration longer, as in case of asthma, or if there is COPD patient, they are retaining carbon dioxide, but you increase the expiratory phase so that it should give more time for the carbon dioxide to come out from alveoli to the atmosphere. So this is a basic principle. In ARDS type of picture, if there is a severe lung infection, then the problem is the oxygenation. The problem is so you will have to increase. If you go on increase the inspiratory phase, if you reverse it, you make inspiratory period longer than the expiratory period, this is called inverse ratio ventilation. That will definitely improve the oxygenation also. So in ARDS, two things are very important. You look at the inspiratory to expiratory ratio, and second thing is the position of the patient. So if it is resistant to oxygenation, you change the position of the patient, particularly you put them on a prone position, and you also change the inspiratory to expiratory ratio, go and increase the inspiratory phase so that it will give better time for the oxygen to diffuse from the alveoli to the blood. Then positioning also, different positioning was ECMO, extracorporeal membrane oxygenator. So I think you people have never seen ECMO, so we put Pasha Sahab on ECMO also to improve the oxygenation. So it takes the blood from the body, passes through the oxygenator and put it back into the circulation. So the lungs, you give the rest to the lung. So the lung is so much diseased, right? So that's ECMO. There's an airway pressure release ventilation also, that also improves the alternative mode to improve the oxygenation. Now, respiratory failure, we have gone through it. Okay, lot. Respiratory failure is two types, type 1 and type 2, then going to ARDS like this. So, but prevention, when the patient goes into respiratory problem, we put them on incentive spirometry. कभी की आप लोगों ने इंसेंटिव स्पायरोमीट्री आईसीयू में तो हम करवाते हैं, फूंके मरवाते हैं उसमें, या आजकल गुब्बारे भी महंगे हो गए. गुब्बारे का पैकेट जो पहले 15-20 रुपए में आता है 200 रुपए में आता है, 250 रुपए में, तो उसको फैलाते हैं. तो इंसेंटिव स्पायरोमेट्री विल ओपन अप द लंग, देन मोबिलाइजेशन ऑफ द पेशेंट, then humidify the humidification, and then nebulization. Humidification will have steam inhalation or humidification. It will only affect up to the respiratory bronchiole, up to the 16th generation of the lung. Then if you want to have effect below the respiratory bronchiole, then you will have to nebulization, because it's a molecule that matters. बार बार मैं इसलिए बताता हूँ कि इसको अक्सर लोग कंफ्यूज कर देते हैं. मेडिकेशन इज अ डिफरेंट थिंग देन ए नेबुलाइजेशन. सो नेबुलाइजेशन the droplet size is 0.2 micron. So, but the droplet size is much bigger when you have steam inhalation. So that is important because we have to humidify the mucosa to have the escalator which is bringing the secretions up and diluting the secretions also. Then we should control the pain of the patient also. If the patient has a pain, particularly when the patient has got a pain in the chest, they never complain. As if they have undergone the cabbage operation or they have got chest injury, they will never say we got severe pain. They start hypoventilating. So you control the patient, you ask the patient, and then you look at the ventilation, whether they are hypoventilating or not. Then you give them strong painkiller, not such a strong that they should go to sleep. They should remain mentally active also, but they should be able to breathe in also. So we'll say immediately, just giving by painkiller, you say immediately your oxygenation improves. Right? You then turning of the patient side to side and making the patient cough and deep breathing. So this is the job of physiotherapist. Actually, basically, up to certain level, it is the job of nurses. Then it is the job of physiotherapist. Right? Treatment, we use medication like albuterol or something like beta, Ventolin and other things, then steroids, and then theophylline is the phosphodiesterase inhibitors, aminophylline and other things. Then we think about CPAP, think about BiPAP, and think about IPAP or EPAP. Then you think about intubation if there is an indication for intubation. Now, important things comes, indication for ventilatory assistance. Is there any indication to put the patient on ventilator or not? That you have to decide whether this patient should be put on ventilator or not. These are a big list of indications for putting a patient on ventilator. If you look at the PaCO2, normal value is 40. If it is between 30 and 40, we take it as a normal. Right. When the PaCO2 goes above 45 to 55, we start thinking that patient should be put on a ventilator if there is another indication. When it goes above 55, it is a must to put the patient on ventilator even if there is one indication only. You don't need to look at the other indicator. When you look at dead space, normal VD or VT, it's a 30%, 30 to 40%. Then when it goes to 50 to 60%, then we start thinking if there is another indication, we should put on a ventilator, but when it goes above 60% or 0.6, so it is a definite sole indication to put the patient on a ventilator. Then we look at the oxygenation. If the patient is breathing room air, FiO2 is only 21. If the normal PO2 is 80 to 90, say, when it goes down to 50 to 60, we start thinking we should put the patient on ventilator. When it goes below 50, then it's a definite indication to put them on a ventilator if it is a sole indication also. Then if the patient is breathing 100% oxygen and the PO2 should be 550 to 600. So if it comes down to, with 100% oxygen, it comes down to 200 to 300. So it seems that it's very high, but it is an indication to put on a ventilator if there is another indication. When it goes down to less than 200, now we look at the blood acid, PO2 is 200, but look at the FiO2 also, how much you are giving. If you give 100% oxygen, but PO2 is around about 190, 120, we say, oh, very good oxygenation. But no, it is the indication to put the patient on a ventilator because you correlate with the FiO2, right? Then AA gradient, normal is 5 to 20. If it goes down to 55, increases to 55 to 60, you start thinking putting them on ventilator. When it is greater than 450, it's a definite indication to put them on a ventilator also. Same about shunting. Now, if the shunt is 3 to 8%, the blood which does not come in contact with the gases. So if it increases to 30 to 40%, then you start thinking that we should put them on ventilator. If it is greater than 40% shunting, there is no choice but to put them on a ventilator. Then you look at the mechanics of respiration or respiratory rate. Normal is 12 to 16. When it goes to 30 to 35, and if there is another indication, then you put them on a ventilator. When it is greater than 35, even if there is no other indication, put them on a ventilator, even if your saturation is normal, even if your PaO2 is normal, but the respiratory rate is greater than 35. It means it is going into impending respiratory failure. Put them on ventilator. Same is the tidal volume. Normal is 6 to 8 mil per kilogram. But when it goes down to 3.5 to 4.9, then this is indication to put on ventilator, but it is less than 3.5, it's a definite sole indication to put them on a ventilator. Then you look at the vital capacity, milliliter per kilogram. Now, is a 50 to 60 is per kilogram is a normal. When it goes down to 10 to 15, then there is indication. Then when it is less than 10, then is sole indication to put them on ventilator. So you got such a big list. It should be in your file. You look at that if the patient comes to do, whether the patient fits in that we should put the patient on ventilator or not. Then you decide, you have put the patient on ventilator. Before that, there are indications for ventilation. Doesn't mean if you put on ventilator, it could be non-invasive ventilation, could be invasive ventilation. That's why I put these indications before the indications of intubation. Because you can ventilate with the mask also. Put them on mask, that is called non-invasive ventilation. Now, indication for intubation, whether you should intubate the patient or not. Though it is a big list of criteria. Tachypnea, respiratory rate greater than 35, hypoxia, PO2 less than 60, hypercarbia, PCO2 greater than 55, minute ventilation less than 10 liter, tidal volume less than 5 to 10 mL per kilogram, negative inspiratory force, 25 centimeter water. This is criteria. So, initial ventilator setting in these patients should be FiO2 50%, PEEP 5 centimeter water, respiratory rate 12 to 15 mil per kilogram, respiratory per minute, then tidal volume is 10 to 12 mil per kilogram. In a COPD patient, it should be less, and ARDS patient also it should be less. And if you want to give precious food, it should be around about 10 centimeter water. So these are the indications you keep in your mind for intubating the patient. Then indication for extubation. Now your patient is off the ventilator, but you have got still the tube in, and you are confused whether you take the patient intubation tube or not. You extubate the patient or not. So you look at the different parameters. So clinical parameters, the original pathology has resolved. Patient is hemodynamically stable, and patient has got intact cough or gag reflex. Spontaneous respiration is good and with a normal rate. Acceptable ventilator setting, FiO2 less than 50%, PEEP less than 8 is required, and pH is 7.5 or so, greater than 7.25. So it means that gives you patient is stable now. Now you have already tried the SIMV mode, you have already given the BiPAP. Now the patient is on spontaneous breathing. Trial also, patient has passed through that. Now the patient is ready to be extubation. Now you extubate the patient and immediately put the mask on it, and you humidify the patient after extubation. And at the time of extubation, when you decide it, you give a little bit of time, give them steroids, dexamethasone, one dose, it will reduce the edema of the larynx, and another dose after extubation, after 6 hours you give them. And make them sit them, humidify the patient and stimulation to the patient. Then you have finished your job. Now in this, before you actually come to the extubation level, you will have to give the spontaneous breathing trials also patient. So there is a big list of successful spontaneous breathing trials. If it is unsuccessful, you give time again, you do the extubation breath. It is individually on every patient, it is a practice like this. So I will not go into detail this, I will go on the next lecture. Now, after successful spontaneous breathing trial, now, you look at the altered mental status and inability to protect the airway. and potentially difficult. If you have done your successful breathing trial, now still you go on ventilating the patient. Why you are still ventilating the patient? Because if these things are still there, like altered mental status and inability to protect the airway, even if he is spontaneously breathing, we will have to go on ventilating the patient till we are clear about the altered mental status. Then potentially difficult re-intubation. If you say, if I take the tube out, if it obstructs again, and it will be very difficult to put the tube down, don't take the tube out. Then you have to choose an alternative way. Then unstable injury to the cervical spine. You have intubated the patient, you have looked at the criteria of extubation, he fits into that, needs to be extubated, but if I got unstable cervical injury or vertebra, so you don't take the tube out till you sort that out. Okay? So breathing is not only criteria, breathing will stop if you take the tube out. Likelihood of return trip to operation theatre. If you think that it is intubated, but he is going again to the theatre for some other problem or for another operation. So what would you get by extubating that? Keep that intubated patient, keep them on his or her spontaneous breathing, and till the theatre problem is over. Right? Need for frequent suctioning. If the patient requires suctioning again and again, and you don't extubate even if the spontaneous breathing test has been positive, because otherwise all the secretion will start collecting in the lung. So wait till the secretions are dried. Right? Tracheostomy. Now the patient is on intubator and on ventilator. Now you will have to judge. A standard rule is 7 to 10 days. If it passed and the patient is still on ventilator and tube is in, you should choose. That's the indication to do the tracheostomy. And if you plan that patient will be needing prolonged ventilation or prolonged intubation, so avoid the complication of intubation. You put them, do the tracheostomy and put them on that. So it will be very easy to have a proper nursing care, and it will decrease the work of breathing also. It will avoid continued vocal cord injury with the vocal, because the tube is passing in between the vocal cord. It is putting pressure on it, and it is damaging the vocal cords also. And improved bronchopulmonary hygiene. So you can look at the lungs properly and you can suck the secretions properly. Then improves the communication with the patient also. You have taken the tube from the mouth, and the patient's mouth hygiene is also very easy, and you can make the patient communicate with you also properly. इशारों से बता सकता है, अगर आप कफ को डिफ्लेट करेंगे आपके साथ बात भी कर सकता है if he is in a position. So that's very good way of communicating with the patient. Now disadvantage is long-term risk of tracheal stenosis. Yes, if this tracheostomy tube is in and your cuff is inflated, if you are not carrying the cuff properly, so then due to continuous positive pressure on the mucosa, there will be fibrosis, and that fibrosis will cause a stricture of the trachea also, and that's very dangerous. So when the patient comes to that stage, so you are required to you are required to deflate the cuff. But always remember, you have got a cuff, whether it is a tube or a tracheostomy tube. So above the cuff there are a collection of secretions. What are those secretions? Those secretions come from salivary secretions, and salivary secretions are alkaline secretions, and alkaline media is very good for the growth of bacteria. So they are infected secretions. If you release the cuff without sucking them, all the secretion will go to lung, and this is the most important cause of ventilator associated pneumonia. Always make it sure that you have sucked the secretion which are collected below the vocal cord above the cuff. After suction, then you deflate the cuff gradually, then keep it deflated intermittently. Make your habit like this, so that you release the pressure of the mucosa, so that it should not cause the permanent damage to the mucosa of the trachea. Okay, I'll finish it over here. Next lecture will be on the physiological effects of ventilation. That's very important. Then at the end, disease-oriented ventilation. Then I'll bring the ventilator. I'll show you how to set the ventilator setting, whether it is a pressure controlled or volume control on that, and see the effect on the screen. Thank you.